everyone. My name is Hai Liang. I'm the moderator for this session today. Today we have Dr. Fong, a UMMC neurologist. I've heard quite many good things from my batchmates who had you as a supervisor last year. And I have to admit my neurology is not that good because I haven't seen many different stroke cases. So I'm very honored to have you here. I'm sure everyone is to have you here talking about the cases. So Dr. Fong, you want to introduce yourself a bit?
Hi, I'm Dr. Fong here. I'm technically not a certified neurologist yet. I'm still a trainee. But yeah, glad to have you guys at this platform to teach you all what you want to learn. To cut the story short, maybe we should just start the session.
Okay, sure.
Yeah.
Okay, so how to okay. Okay, so maybe a little bit of recap because I'm also quite rusty. So this is a table that I've got from I downloaded from the USMLE book screenshot. So one problem I have with distinguishing stroke cases, right, doctor? So
Mm.
you see, almost all of them are like you see, middle cerebral artery infarct also will contribute to paresis. Then anti-ACA also paresis, lacunar stroke also paresis. Even yeah. So I'm quite confused by the whole thing lah. So maybe you can just explain a little bit.
Okay, the diagram that you're showing is basically is a little bit similar to the classification that we use, which is the Oxfordshire Stroke Project classifications, where we divide the patients into either it's a total anterior circulation infarct, partial anterior circulation infarct, lacunar infarct, or posterior circulation infarct. Well, clinically, they all present almost the similar way, but there are ways to actually tell us as whether this is clinically likely to be an MCA infarct or clinically likely to be an ACA or a posterior circulation. So if you were to look at the middle cerebral artery, obviously it can actually cause hemiparesis or hemisensory loss. But then at the same time, because it also affects, so the middle cerebral artery actually also affects the speech area if it's on the dominant hemisphere. It gives you what we call as the cortical sign, where the patients would not be able to talk, what we say aphasia. It can be global, which means comprehension and expression both are affected, or it can also be just predominantly the expression that is affected. You can also look for other cortical signs. So aphasia is actually one of the cortical signs. The other one is actually neglect. You have visual spatial neglect, you have sensory neglect, and also impact to point discrimination as well. So these are the signs that help to tell us that this is likely to be an MCA stroke. But ACA usually, as you have pointed out in this table, usually it's the involvements of the lower limb. They can have hemiparesis, but the lower limb weakness might be more severe than the upper limb because you know your ACA territory supplies the area in your motor homunculus, which involves mainly the lower limb. Posterior circulation artery mainly involves either the occipital lobe or the brainstem. So you were to look into the signs of that the brainstem infarct can gives you, which is cranial nerves, vertigo, giddiness, ataxia, which is from the cerebellum, and also homonymous hemianopia from the occipital area. Lacunar stroke is the 5 types, which is pure motor, pure sensory, ataxic hemiparesis, or a mixed sensory motor, or a clumsy hand. So these are those patients who usually have no cortical signs, but clinically sometimes it's a little bit difficult for us to decide whether or not this is lacunar or whether or not it's MCA. The small penetrating arteries or basal ganglia usually presents as lacunar.
Okay. So we have a question here. So Dr. Fong, for TIA, do all patients recover
Yep.
within an hour?
Usually no, by definition it's 24 hours lah.
But
Yep.
I've read somewhere, I think Kumar and Clark actually said that they don't no longer use the 24-hour definition already. Is that true or not?
Yeah, so the new one actually says it recovers in an hour, but at the moment we're actually still using the 24 hours one. So to distinguish whether or not it's a TIA or it's a real stroke.
I see.
Mm.
Okay. So if not, I think we can move on to the next
Yep.
question. Next
Okay.
slide. Okay, so these are the lacuna stroke. I think probably no need to go into detail lah, this one. Or do you?
Yeah.
No need lah. Okay, so this is another diagram I just stole from Kumar and Clark. Uh,
Okay.
so uh, so this is the for the ischemic stroke, right? So I have a few questions lah about this, like for the thrombosis, the sagittal sinus thrombosis, cortical vein thrombosis. Oh, these are venous thrombosis, right? I'm not
Yes.
sure why it can cause a stroke that is similar to ischemia or infarction.
Okay, so if you look at the blood circulation, so artery supplies oxygen in, it goes into your tissue. Once it's consumed, then it will be, so the venous blood will be drained out. So either way, if you block the artery, it would actually cause impaired blood supply. It can also cause ischemia to the tissue distal to the area of blockage. But if you block the venous, it can actually affect the venous drainage. By then, it can also cause an ischemic insult as well. So both of them, whether or not it's an arterial occlusion or it's a venous occlusion, both can actually cause infarct. But usually, if we are going to use the word arterial occlusions will give the name of ischemic infarct. But if the infarct is actually from the venous, we will usually use the term of a venous infarct in this case.
I see. Okay. Okay. Yeah. One more thing. So yesterday in our brief conversation, we mentioned about seizures and stroke. So I'm still not quite sure how is it uh how is it really related? Is it common or not common? Like you mentioned, it's not common, right? The stroke. Seizures.
Acute stroke with seizures usually not so common,
Mm-hmm.
but if you have a stroke, let's say like 5 years ago, 2 years ago, or 6 months ago, it's actually more common than the stroke that happens within, let's say, 2 weeks after the stroke. So this is what we call as early onset post-stroke seizures and also the late onset post-stroke seizure. We take a cutoff of 2 weeks. So those that happens after 2 weeks of the seizures are those that is due to scarring. These are considered the group of high risk of getting recurrent seizures that's likely to require a long-term anti-epileptic drug use. Mm. Yep.
Okay, so another last question about the stroke thing. So I've
Mm.
read in this Kumar and Clark again, it mentioned something about a limb shaking TIA being pathognomonic for ICA stenosis. Is that a thing or not?
Sorry, come again. I was looking at the question. Sorry.
Yeah, so I've read in Kumar and Clark about something called a limb shaking TIA. Is it similar to a seizure or is it not really?
It is technically not a seizures. It is because of it is actually an ischemic event leading to that limb shaking thing, rather than a true seizure. So seizures, when you have it, is due to an abnormal electrical signals or an excessive electrical signals firing from the brain. But if it's limb shaking, it is ischemia related, or, but it's not related to an abnormal electrical signal from the brain.
I see.
Yep.
Okay, so a few questions. So,
Yep.
doctor, how do we differentiate between thoughts paralysis and a stroke?
Okay, in an acute setting, the only way that you can tell this is a thoughts paralysis is that patient had a seizure and then they develop weakness. So if it is a stroke to begin with, usually it's a straight weakness without a preceding seizures. So that's why if you were to look at our contraindications for thrombolysis, you would find that there is a contraindication saying that if the patient presents with seizures and then with the weakness, we usually don't thrombolyze them because you don't know whether this weakness is due to a seizures or is actually because of a true ischemic event. So if the patient gives you a story of fits and then had the weakness, you can say it's a thoughts paralysis, but unless it's actually very, very persistent, even after about a week, after the seizure and the patient still had a weakness and your CT brain clearly shows an area of infarct or hemorrhage, then you can say the weakness is because of the stroke. But yes, so if you have a seizures and then you got a weakness, you still can say it's a TOTS paralysis.
Okay.
Yep.
So another question from. Sorry. Okay. So another question from Lee Sing. She asked if the venous infarct is similar to actually not clear. What's this? Lee Sing, can you ask again the question? I don't understand.
I think she might be asking whether or not the venous infarct present the same as an arterial infarct. Not sure. Did I get the question right?
You think?
Okay, disappeared already.
Okay.
Okay, so venous infarct usually, yeah, okay, never mind. Venous infarct usually presents with things like they can have focal neurological sign, which is your hemiparesis, but it's more common for them to also have headache because when you have venous thrombosis, you tend to have an increased intracranial pressure and it tends to present with seizures as well. Yes, and you also need to look into the risk factors. So this is how a slight difference between a venous stroke and also an arterial stroke in terms of their clinical presentation.
Okay.
Mm.
So I think that should be all.
Mm-hmm.
Then I think we can just move on to the next. Okay, so we've now gone into the prompt. So I
Okay.
just read the prompt aloud lah. So
Yep.
Madam Lu is a 34-year-old female presented to the emergency department with an acute presentation of a right-sided hemiparesis. Okay, so I think this is quite okay lah. So for the right-sided hemiparesis, it presented about 8 hours prior to admission. So it started in the morning when she felt numbness in her right fingers, which gradually progressed to become weakness involving the right upper and lower limb. The numbness was described as pins and needle sensation in her right hand. The patient is also right-handed. So the right-sided hemiparesis involves the whole upper limb and the whole lower limb, but the numbness only localized at the right hand. It's also associated with slurred speech, nausea, headache, an unstable gait, and right-sided back pain. Okay, so doctor, just like to ask, so listening to this presenting complaint, do you think it is enough, or do you think we should ask more?
If you are looking at other differential diagnosis, I think it's I would want to know whether or not the more history about the headache and when exactly is the time of onset.
Mm. It started 8 hours ago lah, so is that
Okay. All right. And that right-sided back pain also, what is the durations, when did it started, and the unstable gait as well. Does she has chronic headache? Does the gait problem started together when she has the hemiparesis? And also the back pain, is it together or has been there for some time? But overall, as a shift complaint, I think it's the shift complaint is actually quite clear. Basically points to you that there might be something wrong in the possibly the central nervous system lah.
So about the pins and needle sensation, just like know how come it's like a little bit different from the presentation with, shouldn't it be together or is this normal?
Together as in?
Together as in the distribution is equal.
It depends. Sometimes the problem with the sensory symptoms is that patients may not be describing it accurately. So if a lot of times when they say numbness, it's just very vaguely telling us that, oh, maybe it's actually the fingers, maybe it's actually part of the arms only. So usually the only thing we want to know is whether or not there is a sensory involvement rather than you know where exactly is the distribution, unless in the later physical examination you find something, the clinical neurological sign that does not tally with your chief complaint. Then I might actually go in and dig further regarding the pins and needle sensation thing. But as for now, I would just take it as it is together with that hemiparesis lah. Probably won't dig in too much about pins and needle sensation the right hand.
All right.
Mm.
Okay. So I think we can move on.
Yep.
So a little bit more about the slurred speech. It occurred together with the hemiparesis about 8 hours, but it's not associated with any facial weakness. Patient also had nausea, which is also occurred around the same time as the hemiparesis. For the headache, it's a bit special. The first episode lasted about 2 hours and occurred one day prior to this episode, which led to the admission. It resolved with 2 tablets of paracetamol, and the severity is mild, about 4 out of 10 in the pain scale. Second episode occurred about 2 hours after the right hemiparesis occurred and is persistent until admission. Severity is about 7 out of 10. Both episodes are described as a bilateral generalized pain in the head. It's not localized to any one area. There was no photophobia or aura. And so for the right-sided back pain, the history is about a few months, and it is, oh sorry, not caused by, it led to disturbed sleep in the patient. So it's a right-sided back pain, but not really specific where. Doctor, you mentioned wanting to ask more about the right-sided back pain. May I know why, doctor?
Not sure how relevant it is, but because if it's a young patient with headache and also a stroke, that back pain might suggest that she might have thrombosis elsewhere in the body.
Mm,
Yeah, which may involve, you know, things like rare places like the spinal artery that can gives you some back pain, or and also lower limb weakness as well. But usually it's paraparesis or paraplegia lah.
mm,
Not sure how much is the relevance of back pain here, but if you were to look at the headache, it's actually very interesting that the headache comes in episodes. And does the headache disappears completely in between the headache? Sorry, does the headache disappears completely in between the episodes?
yeah.
Like in interval, she's completely well.
Yes, yes.
Okay. And so if the headache is actually bilateral, and why is there a history mentioning that there is actually no aura?
Oh no, it's just something they asked lah in the history.
Eh,
So I thought
okay.
maybe it's relevant or something.
Yeah. Okay.
So for the headache, right, doctor,
Mm.
is it not relevant to ask about photophobia or aura?
I would be more interested. Okay, if you ask photophobia and also aura, I am taking it as a sign that you're trying to tell me whether or not this is actually a migraine or not.
Mm-hmm.
So, which is a little bit not so common. I mean, like a little bit um, uncommon if you tell me the headache is already bilateral, but at the same time you tell me there's no photophobia and aura. I mean, no harm asking, just
Yeah.
as a signs to rule out whether or not this could be possibly a migraine. But I don't see so much of relevance of mentioning that aura and photophobia here under the segments of headache. You can sell it if you think this is actually a meningitis. Then I would be interested to know there is or there is no photophobia.
With the neck
Mm.
stiffness and all that lah.
Yes.
Mm-hmm. Doctor, just like to ask, right? So I've read somewhere that in hemorrhagic stroke or
Mm.
anything with raised ICP, you also have headache, nausea, then after that papillary edema,
Yes.
all that. So do you think we should keep that raised ICP in mind?
You can, but the only thing is raised intracranial pressure usually gives you more persistent headache rather than episodic.
Mm,
And your patient is actually having like an intervals with headache, which is free from headache, which is make it a little bit less likely to be intracranial hypertension, but still possible. Mm.
I see.
Right.
Okay, so I think we can move on. So the systemic review is as follows: no
Mm.
fever, no vomiting, no neck stiffness, no uh, drowsiness, no visual disturbances, seizures or memory loss. No recent trauma history, no loss of appetite, loss of weight, or night sweat. Okay. So,
Okay.
you have anything to add, doctor?
Anybody has anything to add in the history that is missing? No reply. Okay. So what is your provisional diagnosis, or what are the differential diagnoses that you are putting in this case so far? With a complaint of hemiparesis and hemisensory loss, and the patient has headache. You will only know what else to ask if you have a pretty good number of differential headaches. Differential diagnosis. Yeah.
Tang Chingwen said, can it be due to an hypertensive emergency or hemorrhagic stroke?
Yes, it can be, but again, the headache usually are quite persistent rather than episodic.
Okay.
All right.
So I think my provisional now,
Mm.
without any further, I think I would still think that it's a hypertensive emergency.
Okay, but does your patient has underlying hypertension? Not yet.
Okay, yeah. So it's not yet lah. So
Okay.
right now, I think I'll still put hypertensive.
Hypertensive emergency. Any other diagnosis or differential diagnosis that you want to give? Or anybody?
Anybody else want to try?
There are at least a few, like you cannot be just having, I mean, when you're just looking at the history, usually there are a few things that you can figure out from the history.
So for me, I think maybe we can consider a TIA since it's within the 24-hour span.
Okay, possible. Can it be things like cerebral venous thrombosis?
Yeah, it can be.
Why?
Is it because of the headache?
Yes, and she's a lady and she's young as well. Okay, so you've got hypertensive emergency with a hemorrhagic stroke, you have got TIA, and you've got cerebral venous thrombosis. Okay, 3 differential diagnoses. I think it's pretty good already. Okay, you want to move on to the next slide?
Okay. So for the next slide, okay. So for the past medical history, the patient does have a history of hypertension. So she claimed that her systolic BP has always been around 140 to 150. When she went to the GP just told her to change the diet and regularly exercise, with no further investigation being done and no further medication. Second, the patient also has an underlying polycystic ovary syndrome, diagnosed 10 years ago and was on Yasmin, which is drosperinone and EE17, but stopped 6 months ago because she was worried about the weight gain side effects. For the past surgical history, is no significant past surgical history. Currently, she is taking some Chinese supplements for menstruation, and she regularly takes fish oil and something called royal jelly. So next, allergic history. The patient's allergic to seafood.
Sorry, can we go back to the previous slide?
Yeah.
Okay, so the past medical history here, I think is quite helpful in terms of supporting your differential diagnosis. So again, just a recap, what were our differential diagnosis just now?
Okay, so first is a hypertensive emergency.
Okay, so do you think it's possible for her?
Yeah, it's
Yeah,
possible.
with the underlying young hypertension. So not sure whether it's adequately worked up or not, but apparently she's not on any medication for that. So our second differential diagnosis is cerebral venous thrombosis, correct? Do you think she has got risk factor for cerebral venous thrombosis?
I would say yes because of the OCP use.
Yeah, but she has actually stopped for 6 months already. So not sure whether or not it's relevant here, but likely not if it's 6 months. But look at your last sentence in the drug history. She's also taking some Chinese supplements. We're not sure what's the content inside that. Okay, so this actually helps in terms of supporting your differential diagnosis. I saw Emily asking steroids from Chinese supplements. Yes, so that steroids in the Chinese supplement may increase the risk of getting things like diabetes, hypertension, and also high cholesterol. which are all risk factors for getting a stroke as well. All
And
right.
can you ask about for cerebral venous thrombosis, the headache is persistently worsening or is it episodic?
Usually it's persistent because your thrombosis is always there, and your once it's infarcted already, and the thrombosis can actually cause cerebral edema there. It is a persistent thing until you treat it and you remove, not to say remove the thrombus, you try to prevent the propagations of the thrombus. So as long as the insult is there, the raised intracranial pressure usually is there. So the headache is usually persistent rather than episodic.
Mm.
Okay.
Okay. Could it be that the thrombus will be dislodged, maybe somewhere down, and then it travel up, and then cause the thrombosis, and then causing the presentation of an episodic headache?
No, still once you've got the thrombus stuck there, usually the insult is persistent, so the headache will still be persistent.
I see.
Yeah.
Okay. So we can move on now, I guess.
Yeah, sure.
Okay. So for the allergic history, the patient is allergic to seafood, which will cause facial edema and also some hives. For family history, both parents have hypertension with no family history of any heart, kidney disease, stroke, or cancer, or any what's that called? Collagen disorders. For the social history, the patient is currently single, working as a client manager. She is an occasional smoker, which she started in her 20s and occasionally smokes 1 to 2 cigarette sticks every 2 to 3 days. Alcohol, she occasionally drinks 1 to 2 tins of beer during social events. No history of illicit drug use. So, okay, so doctor,
Mm,
this is one question that I've had now. I'm not sure if
mm.
it's relevant or not, but should we take a sexual history from this patient?
I think it's relevant, but why would we need that?
Maybe because pregnancy would be another predisposing factor for the cerebral venous thrombosis.
Uh, okay, not entirely wrong, but there is actually another reason behind why you're asking sexual history.
Hmm. Uh, Anyone want to try?
Anyone?
So can it be like the patient is already due to sexual history? Maybe the patient is HIV positive, therefore causing something like toxoplasmosis or PMV or something like that.
Well, yeah, can in terms of a CNS infection, but the HIV itself actually can cause, it's relevant in terms of causing things like stroke. And you also are concerned whether or not the patient could be syphilis. Yes, Adrian mentioned that. So syphilis can cause vasculitis as well. So it's actually one of the workup that we do for patients with young stroke. So yes, I would say taking a sexual history is important.
Okay.
Right.
Okay. So if we have nothing, we can move on.
Okay.
All right. So next, anyone have any question? No. Okay, so for the physical examination, we just start off with the vital signs. The heart
Mm.
rate is actually 80 beats per minute. Respiratory rate is 18 breaths per minute. Blood pressure is 180 over 125 millimeter mercury with a temperature of 36.7 degrees Celsius.
Mm.
So the general examination is the patient is alert, conscious, and pink on room air. She has a large body habitus with the BMI about 35 kg per meter squared. She is restless but lying supine on the bed. The GCS is 15 out of 15 and no neurocutaneous stigmata seen.
Okay. Can I ask what are the neurocutaneous stigmata that you're looking for here? That is relevant to the case of stroke. I'm just out of curiosity asking what are the things that you guys are looking for.
Hello? Okay, I'm back. So I'm thinking something like tuberous sclerosis, like the
Causing a stroke?
no lah, not really lah. It's just something that we I guess I would mention in every examination.
Okay, someone mentioned port wine stain in tuberous.
No, uh,
If you're talking to patients with seizures, yes, I think it is important, including your things like your neurofibromatosis. All that can actually increase the risk of, or they are not say increase, they are associated with epilepsy. But as in for a case on stroke, I won't put too much of attention if you're interested to mention whether or not there's neurocutaneous stigmata.
even in a young stroke.
Young stroke, not really. Okay, young stroke also, yeah, I probably won't be putting too much of attention to that neurocutaneous stigmata.
I see. Muhammad Akmal asked about the meningococcal rash.
Yeah, if there is a rash, you mentioned there is a rash. So neurocutaneous stigmata, usually we use that term to mention whether or not the patient has got things like cafe au lait spots, ash leaf spots, and angiofibroma like that. Rather than, yes. So your history is not so suggestive of an infection to begin with. So if you don't mention there is no meningococcal rash, I probably is quite okay with it.
Right. Okay. Anything you'd like to add, Doctor, from this?
Okay, so what is the relevance of mentioning the Glasgow Coma Scale here?
So, Glasgow Coma Scale could indicate something like a acute event, like a hemorrhagic stroke.
Okay, an ischemic stroke can give you depressed consciousness or not? If a patient has a stroke in the brainstem, can it cause depressed level of consciousness?
Oh, yeah.
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 Okay, so the GCS itself does not tell you whether this is likely to be. In fact, even the BP is high, the patient comes in with headache, the patient comes in with hemiparesis, you cannot tell whether this is a hemorrhagic stroke or a ischemic stroke until, of course, you do a CT brain for the patient. Okay, so the GCS here is important to tell you, number one, what's the level of consciousness. So if your altered mental status is actually also one of the cortical signs that you are looking for. All right, so just now we have mentioned neglect, we have mentioned language or speech problem as two of the cortical signs. So now we have got another cortical sign here, which is altered mental status. It's better for you to spell out what are the components in GCS if you're looking for, rather than putting as a 15/15 score. More useful if you have a patient with MCA infarct and the patient has expressive aphasia. Okay, but otherwise alert can follow command. Your GCS would be E4, V is going to be 1 because there's no speech output, correct? But M is still going to be 6. Okay, so the total score would be 11. If you just tell me these patients, which is the one that I just give you an example, expressive aphasia but otherwise can follow command, the GCS would be 11. If you just tell me 11, GCS is 11 out of 15 without telling me the components, my impression is that the patient actually is not fully conscious.
I see.
Mm.
So, Doctor, yeah, continue, please.
So it's more useful for you to just spell out what are the components of the eye openings, the verbal, and also the motor that you are mentioning, rather than just give a total score like that.
Okay, so we have a question from Lu Kim Ki. He asked about after looking at the BP, can I say that she has a hypertensive emergency that led to a stroke?
Yes, of course.
Okay, but
Okay.
okay. Oh, I forgot my question. Okay, never mind. Yeah,
Never mind, if you recall later, you can ask me.
yeah. Okay, so can we move on, Doctor?
Yep, sure.
Okay, so this is the upper limb examination. Upon inspection, the both limbs are symmetrical, no muscle wasting, no skin changes, no fasciculation, no pronator drift or rebound phenomenon. Tone is normal bilaterally. For the power, right shoulder abduction and adduction is 4 out of 5. Wrist flexion is 3 out of 5. Wrist extension is 4 out of 5. And the finger abduction is 0 out of 5 on the MRC grading scale. The left upper limb is normal with 5 out of 5 across all joints. Tendon reflexes are 2+ bilaterally. Pinprick and proprioception is intact and equal in both upper limbs. No dysmetria, no dystiotoconesia. Hoffman's reflex is negative. Okay, so doctor, looking at this upper limb examination, do you have anything to add?
Not really. Anything you want to ask about it specifically?
Yeah, so how come the tone is normal, the tendon reflexes are normal?
Okay, in an acute setting, usually you would see an increased tone so fast. And in fact, right after a stroke, if you go in, like within hours, if you're going to examine the patients, you might find that actually the tone was either normal or actually reduced. Increased tone usually develops after about a week post-stroke. So even though it's considered a sign of upper motor neuron lesions, you probably won't see it so soon. Same goes to the reflexes as well.
I see.
Okay, one thing that you guys need to be careful in terms of assessing the coordination, as in the dysmetria in this dysdiadochokinesia in the patients with upper limb weakness, if the power is about 3, generally 3, usually if they couldn't really do the finger nose test and they cannot do they're a bit clumsy on doing your dysdiadochokinesia assessment, you probably won't be taking that into such an important point, because the problems with coordination might be contributed by the muscle weakness rather than a true incoordination problem. Yep.
I see. So, doctor, during our discussion, right, you mentioned that Hoffman's reflex is for the spinal lesion, is it? Or
We usually look it up in patients with myelopathy. Well, personally, I actually don't check Hoffman's if it is a stroke patient lah. Yeah. So stroke patients usually we really actually don't examine the Hoffman's in that. More interesting if you find it in well, of course it's actually upper motor neuron sign, but usually you find it more in a spinal cord or in patients with myelopathy.
would you say that the Hoffman reflex is equivalent to or equal to the Babinski sign?
No.
How so?
As in, why is it not equivalent?
Yeah. Because from what I searched it says that it's equivalent, but there are some differences, but I don't know what. It's not really sure lah.
I also don't know how to answer your question for that. But practically, I personally don't assess Hoffman that frequently lah. So usually, I actually don't like bother to look at the Hoffman's reflex. Yep.
Okay. So I think we can move on.
Yep, sure.
Okay, so this is the lower limb. Okay, yeah. So this is the lower limb examination. So again, infection is symmetrical, no muscle wasting, no scar. Okay. Maybe I just continue first. No muscle wasting, no scars, no deformities or skin changes, no fasciculation. Tone also bilaterally normal. Power of the hip flexion is 2 out of 5. Right knee extension and flexion is 4 out of 5. And the ankle plantar and dorsiflexion is 0 out of 5 according to MRC grading. Left is normal power. Tendon reflexes are 2+ bilaterally. Ankle clonus not negative, positive Babinski sign. Pinprick and proprioception is normal and able to perform heel shin test smoothly on the left leg but cannot do it on the right leg. Gait assessment and Romberg test unable to be carried out because the patient is a high risk patient.
Okay, Babinski sign, I would say it's probably better for you to mention whether it's upgoing or downgoing rather than positive or negative. Negative means it is downgoing or it's actually not there. It's very confusing.
I see.
Yeah, so just a term, using of a term. Yep.
Okay. So negative means it's not present.
Yes, or usually what I do is if it's there, you just mention it's upgoing or downgoing. If it's not there, you just say it's actually absent.
Oh, why would it be absent, doctor?
You would have it absent in patients who are not fully relaxed, or those with peripheral neuropathy, with loss of peripheral reflex, with depressed or loss of a deep tendon reflexes.
Okay, so like the lower motor neuron lesion kind of thing lah.
Yes.
Okay.
It's just a plus point to tell you if it's outgoing that, this is very likely to be an upper motor neuron lesion. But if it's not there, doesn't mean that it's not. A lot of stroke patients, when we see them for the first times also, they might actually have a downgoing or it's actually an absent Babinski sign.
I see. Okay, so maybe we can move on to the
Yep.
the cranial nerve didn't do lah, so that one a bit.
I supposed to do supposed to do cranial nerve because the patient comes in with the problems with slurring of speech, right? So how do you know whether? Sorry.
Yeah. Do we need to do at least the what you call it, the H test for the visual?
In all situations allowed, you are supposed to do a full neurological examinations, meaning that upper limb, lower limbs, plus cranial nerve, if possible, the gait also. There are no exceptions in conditions where you cannot examine the cranial nerves, so you cannot examine the gait. As much as possible, you try to examine all. Your patient comes in with a slurring of speech. How do you know whether the slurring of speech is not because of a tongue movement problem, which is the hypoglossal nerve problems, or it is, or if they don't tell you that they've got facial numbness or facial weakness, when you examine them, they might have it. It's just that it's too mild for them to notice. So you still need to examine that. Yeah.
Oh yeah, I remember my question already. So the slurred speech in this patient, right? So from what I've read is that slurred speech would be classified as a dysarthria. Is it similar to an aphasia or is it like completely two different things?
No, dysarthria is problem with articulation. It's a mechanical, not to say mechanical problem. So problems in pronouncing words, and people would otherwise understand if the words are clearly. It's more of articulation problem, but aphasia is a speech and language problem. So if you were to communicate with people in your language, you need to first understand what people are talking, and then you express what you want to tell. So that is aphasia. So it involves things like comprehension and usage of words, whether the grammars are correct or not, the words are correct or not, and whether or not they can find the correct words in expressing themselves. That is the components in speech and language, which if impaired gives you dysphasia or aphasia. Dysarthria is a completely different thing. So it's just problems with articulation. They are otherwise normal in comprehension and normal in the grammar should be correct. The words they use should be correct as well.
I see. Okay, Chuning has a question. So she's asking if there is any significance of the recovery in jerking motion that this patient initially had. Oh,
I think Highland, you removed the sentence of
I
the
removed
involuntary.
the
Yeah, so yesterday when I saw the slides, I was actually a bit confused and why does this patient have jerking movement? I'm not sure whether it's generalized or it's focal. So maybe you want to just refine your question as actually who provided the stem of the patient having involuntary movement.
I think she's not here, but she's one of our juniors.
Okay. If she had jerking means if okay, let's just take the event if she has got generalized jerking. All right, and then she got a hemiparesis, and then she's got a headache. That would actually affect the way that I arrange my differential diagnosis, which one to put on top, which one to put at lower down level. So if you have fits, if you have a focal neurological sign and also headache, I would actually put my differential or provisional diagnosis as cerebral venous thrombosis first, then hypertensive emergency and a stroke. The recovery in jerking movement that this patient initially has, I really have no idea, but I would like to know about the further history of that limb jerking movement that was mentioned previously in the slide.
Okay, so I hope that answers the question. I hope the other people are not confused why suddenly jerking movement.
Yeah, there was just for your information, there was a sentence in the previous slides, I think the first or the second one, where the patient has got jerking movement. So yesterday when I was going through the slides, I couldn't understand what is this joking movement, focal, generalized. So I asked Hai Liang to probably just delete the sentence really. Yeah.
Okay. So Lee Sing has a question. So she's
Mm.
asking, how do we differentiate thoughts paralysis from a uh, venous thrombosis, since both of them can present with seizure other than severe headache in the venous thrombosis?
Okay, thoughts paralysis is you had seizure, usually focal of course, and then you have weakness on that limb that you were jerking.
Mm.
Okay, venous thrombosis is you have headache, you have seizures also, but depends, the seizures can either be a focal or it could be a generalized seizures. Okay, so your headache would be one of the adding points to tell whether or not this is venous thrombosis. Well, by the time that you make a conclusion whether or not the seizures is secondary to venous thrombosis, you would already have a brain imaging to tell you whether or not this is just a focal seizure or a seizure related weakness or is actually a venous thrombosis related seizure and weakness.
Mm.
Yeah.
Okay. So I hope that answers the question. So any more questions? Otherwise, we can move on. There's like 15 minutes left. Okay, so I'll try to summarize the case. So, Madam Lu is a 34-year-old female with underlying PCOS and young hypertension, presented to the hospital with an 8-hour history of right-sided hemiplegia associated with headache and slurred speech. Physical examination reveals reduced power in the right upper and lower limb and positive Babinski sign. So now, okay, do you want to elaborate on this or should we move on, Doctor?
I think we can move on.
Okay.
Yep.
So right now, our provisional diagnosis is hypertensive emergency. Is
Mm.
it? Can it be or?
I would probably put hypertensive emergency with stroke,
Mm-hmm.
and my differential diagnosis would probably be throughout cerebral venous thrombosis lah.
Mm-hmm. Uh,
Uh, yeah,
then after
two.
that, maybe TIA.
Yeah, TIA, yes, but you will probably need to wait until your further assessment to decide whether or not it's reversible or not. Mm.
Mm-hmm. Any more differential diagnosis that we can put? Maybe the audience can.
Not that I think of at the moment. Yep.
Mm. Anyone wants to add anything to the slide?
Anyone to give some differential diagnosis for this case?
Because I think we can rule out the infective causes already. Uh,
I
not really, yeah.
probably won't say to rule out entirely the infective causes because your headache might still be due to meningitis.
Mm-hmm.
We'll see if you don't find any causes on neuroimaging, then you possibly need to do a lumbar puncture because not every patient who had meningitis would have fever, would have neck stiffness.
Yeah.
So it's just that a way of how you arrange which one is your priority, which one are the things that you want to look for first.
Mm-hmm. Neoplastic, uh, not really. Can neoplastic be? Neoplastic causes?
Yes, it can be, but that one you will need your brain imaging to look for it. And of course, you need to, if it's a secondary brain metastasis, your history of constitutional symptoms would be very relevant, which in the previous slides you already mentioned the patient does not have loss of appetite or loss of weight.
Mm-hmm. Yeah. So demyelination, this
Okay,
kind of.
demyelination, I would say if you really want to put that as your differential diagnosis, put that at the very, very bottom, unless you have this patient presents with previous history of transient neurological signs that comes and then it resolves, that lasts for at least 24 hours and then it resolves, and then it comes again at another site. Then yes, I would say possibly it's demyelination. But looking at other things, your demyelination you will usually not be your provisional diagnosis
Mm-hmm.
at the beginning of any case.
Traumatic, no lah, because no trauma. And
I would say, okay, if an old patient comes into you who is also an alcoholic, even though there is no history of trauma, as when you ask from the patient, sometimes subdural hematoma could still be your diagnosis because they might actually forgot that when they fell and then they couldn't recall the event. So you will not be able to entirely rule out the subdural hemorrhage until you do a CT scan for the patient, of course.
And lastly, TOPS paralysis lah.
Yes.
Okay. I think that's all lah. We can.
Yep.
Lu Kim Ki asks for elderly patient, do we need to think of electrolyte imbalance also?
Okay, your patient has a focal neurological signs, right? Can you think of any electrolyte imbalance that can give you a focal neurological sign? Your electrolyte imbalance is a systemic problem or a focal problem? Or a local problem?
Systemic.
Yeah, so systemic signs usually gives you systemic problem gives you systemic signs. If there's any weakness, I would expect it to be more generalized. Not focal, not hemiparesis. Just a corrections of the word that you used just now in your summary. Hemiplegia is plegia means it's complete paralysis. Your patient still have a power of 3 to 4 in the upper limbs. So you probably just change that into hemiparesis. Yeah, correct.
Yeah. Okay. Okay, so we can move on, doctor?
Yep.
Okay, so we move to the investigation. So, okay, so investigation-wise, for this patient, from what I've read is that the first priority is to do a non-contrast CT scan.
Yes.
To differentiate the ischemic or hemorrhagic etiology.
Yes, correct. I probably won't mention an MRI as my first investigation because it takes time to do it, and also not every center has a readily available MRI machine to do that. A CT scan is actually good enough to tell you whether or not there is a bleed. Okay, if there's no bleed there, if you still think clinically it's a stroke, then it actually can be an ischemic stroke. It's just that it hasn't showed up properly on the CT scan yet.
Okay, so then after that, maybe you want to take the coagulation profile, capillary blood glucose, lipid profile, because all of these things actually, I think I've read somewhere that they are contraindication to add lab days. Like
sorry, contraindication for
the RTPA.
Okay, yes. If they are having something like coagulopathy, obviously you don't want to give them the RTPA, which is the alteplase. Capillary blood sugar, if it's hypoglycemic, usually we'll correct that. Sugar, if it's a bit too high, sometimes we'll correct that as well. Taking hyperglycemia as a sole contraindication to thrombolysis, we have not been doing that yet. If we can actually bring it down after giving a dose of insulin, then if the patient is indicated for thrombolysis, we'll still try to proceed with that.
And the blood pressure of this patient itself already more than the what's that called? Diastolic blood pressure is 125, so it's already a contraindication, right, doctor? Or do we try and bring it down, like what you say with the blood?
It's not a contraindication. If you're able to bring it down, then thrombolyze. You bring it down first before you thrombolyze. Provided after your blood pressure comes down, you're still within the time window to give alteplase. It is high blood pressure is not a contraindication.
So what are the absolute contraindications for the RTPA?
Absolute contraindications. Okay, if you have any, yes, there is actually a long list. Maybe later I'll probably show in the attach the file in the group. But things that we want to make sure at least patients do not have any bleeding tendencies, no major surgery in the previous few months, and no history of an intracranial bleed before, and the patient doesn't present with a seizure, which makes the thoughts paralysis as a potential differential diagnosis. And the rest are things like high sugar and low sugars, things like that. Yep.
I see.
Mm.
So we have a question from Yani Alisha. So she's
Mm.
asking if an MRI is a must if the patient is a suspected lacuna syndrome.
Okay, if I don't see anything in the CT brain and the patient still clinically has got a weakness on one side, clinically looks like a stroke, I will still put my diagnosis at possible. Of course, provided there's no cortical sign, I will still put my diagnosis as a lacunar stroke. MRI, of course, is better if you want to see it, where exactly is the stroke, which vessel does it affect, but it's not something that you do as a early investigation. You can do it later. Mm. If you have the facility to do MRI, of course, you can do it. But if you're in the center without an MRI, you can actually diagnose a lacunar stroke with just a CT brain. So the answer is it is not a must. You can do. If you can't, then it's okay. You still can diagnose lacunar syndrome. Yep.
So it's on clinical grounds and you cannot find any signs in the CT brain. Is it, doctor?
Yes.
Because even in ischemic stroke, you won't see anything until 6 hours after. Is it? I remember reading something like that.
Yes. So that's generally for stroke. Remember, lacuna, their size is actually quite small, so you may not be able to see it even if it's there in your CT brain.
Yeah.
So if it's clinically a stroke, it is a stroke.
So
Having MRI is just a plus point only. Yep.
okay. Kai Xiang asked if a patient presents with limb weakness few days ago, but he's still able to walk. In the morning, the weakness worsen and become a slurred speech. Do we consider the onset less than 4.5 hours and eligible for thrombolysis?
Okay, answer is no. So this thing actually traces back to the questions of when do you take as the onset of a stroke. In your scenario, I would say the onset of a stroke has already been few days ago. It's just that the worsening of weakness and the new sign probably is a progression of the stroke rather than a new stroke going on. So the answer is no, we are not going to consider this patient for thrombolysis.
Okay. So, any more questions? Investigation, renal function test, of course, do for to check the BUN, blood urea nitrogen, check for creatinine, then full blood count to look for any polycythemia vera. Any more investigation you think is relevant for this patient, doctor?
There are actually a long list of young stroke workup if you were to look at. You will possibly need to consider the possibility of connective tissue disease like SLE, which can cause vasculitis. So they can, before that, your CT scan, CT brain plane, if it is normal, and if you want to look for cerebral venous thrombosis, you should also do a CTV as well, CT venogram.
Okay.
Yeah. So, okay, back to the point of blood investigation. You would want to work out as whether this patient has got connective tissue disorder. You will also want to know whether the patient has what we've mentioned just now, the relevance of taking sexual history, whether the patient has RVD, whether the patient has syphilis, both can cause a stroke. You would also want to know whether or not the patient is prothrombotic. In what state it would be prothrombotic? If you have thrombophilia disorder, protein C, protein S deficiency, antithrombin 3 deficiency. Does the patient has antiphospholipid syndrome? Then you need to take your yes, which is everything inside. Anything missing from here? Where's your antiphospholipid? Yes, here. So antiphospholipid syndromes, you need to take the antibody, which is lupus anticoagulant, and also the anticardiolipin. So whatever that you can think of that you can take as blood investigation to rule out all these things in the list, you take.
Training us ECG. Do we need to do ECG?
Yes. Why do we need to do an ECG? Oh, you didn't put ECG there. Okay.
Chuning, you want to answer the question, or do you want me to answer the question?
Yes.
Yeah.
Yeah, Emily answered already, atrial fibrillation. Okay, of course, not just atrial fibrillations, you might actually find things, your patients has hypertension as well. Okay, so if the ECG actually shows you evidence of a left ventricular hypertrophy, that actually tells you how chronic is the hypertension and how uncontrolled it is.
Yeah.
Yeah. Should we arrange a cerebral angiogram for all stroke patients to look for stenosis or thrombosis? No, we don't do a conventional cerebral angiogram, but we do things like CT angiogram or MR angiogram, which is actually good enough for you to see the blood vessels. We don't routinely do for all strokes, okay, but we do for patients who have young strokes. Okay, we do for patients who especially has a brainstem stroke. Okay, that I'm talking about CTA and or MRA. Both are equally good. Okay, now cerebral angiograms are those who you want to further investigate. Okay, if you are looking for evidence of things like intracranial vessel disease with the puff of smoke that you find in Moya-Moya syndrome or Moya-Moya disease, then you will need cerebral angiogram. But it's not something that we will do routinely for all stroke patients. CTA and MRA would be good enough.
Chuning asked, do we need to do an echo for this patient to assess the function?
Okay, I would do for two reasons. Number one, he has got a young stroke. Okay, you would want to look at the heart function, and he's got chronic hypertension. Does he has any cardiomyopathy? Does he has an enlarged left atrium, which increases risk of getting atrial fibrillation? Does he has any intracardiac thrombus, which is showing out thrombus causing a cardioembolic stroke? And also, how much has the uncontrolled hypertension or chronic hypertension has affected the heart function? And in a young stroke patients, you would also like to look for any evidence of a patent foramen ovale. That one you need to do a esophageal echo together with a bubble test, which can cause paradoxical thromboembolism.
Okay, so the investigations were done. So should I go on or?
Yeah, sure.
Okay, so the investigation was done, and then it found actually not much sign in the CT, but the MRI shows there is ischemic is some ischemia lah in the ATA MTA junction. So I don't have the thing, and it's not mine also, so I can only take a word for it lah. I'm not sure if it's because we already talked about how it could be hypertensive, and then suddenly they come up with ischemia. How is that possible, or is it like not?
Yes, it's possible. We cannot say that this patient is hemorrhagic stroke just based on the blood pressure. You need to understand that in an acute stroke period, even in normal tensive patients would be hypertensive. This is how your body compensate by increasing the blood pressure in order to overcome the obstruction, so to reperfuse the ischemic brain. So even if you do not have an hypertension to begin with, if you get an acute stroke, your blood pressure would actually go up, especially in the first 24 hours. So so the BP alone, even if it is sky high, you still cannot tell clinically whether or not this is an ischemic stroke or this is a hemorrhagic stroke.
So you have to do the MRI to see lah.
CT scan is good enough. Not everybody need MRI. CT scan is a good investigation.
Okay.
Don't dispute CT scan.
Okay. So Yip Katron has a question. He's asking how is handedness relevant in a case of stroke?
Okay, I would say it's more relevant in the rehabilitation process of the stroke, okay, rather than has any relevance to do in the acute stroke period. If the patient is right-handed, you probably need a little bit more training and rehabilitation program to adjust how she uses her right hand in the future, and how she can adapt in using her left hand to compensate the impaired functions on the right hand. As in an acute setting, probably it's not so relevant.
Okay, so I think that's all the questions. So I just briefly
Okay, just one thing. Just now you mentioned that the MRI actually shows that there is an ACA and an MCA junction. In fact,
yeah.
okay, I've got the question. Where do you think is the blockage or the occlusion? Which blood vessel?
The what's that called? The communicating artery.
Which communicating artery, anterior or posterior?
Anterior, I think anterior.
Anterior communicating artery connects your
ACA with MCA.
Huh?
No, forgot already.
Okay, communicating artery, if it's occluded, usually it's not so much of a problem. Okay, so if you, where do you need to block for you to get a, yeah, so someone answered ACOM is actually between two ACA. Okay, so where do you need to block for you to get an ACA stroke and an MCA stroke at the same time?
So
okay, Chui Jun says is okay, carotid artery. Kai Xiang narrowed it down to an internal carotid artery. Okay, so it's actually the terminal internal carotid artery where your MCA and also your MCA branches out. For you to keep two arteries at the same time, it must be somewhere that is more proximal than that, which is your internal carotid artery. Okay.
Yep.
Can go on.
All right. So now okay, a bit more clear. So doctor, about the carotid artery, right? So I've read somewhere that they might need to do a carotid end atherectomy if there is the carotid stenosis of more than 70%, I think.
Yeah.
Is that, yeah, we need to do that one?
On the symptomatic side. Okay, if you have a patient who has a right hemiparesis, okay, and the ICA occlusion is at the right side, and it's more than 70%, you probably don't do anything. Okay, because it's not the symptomatic side. Correct. Your right hemiparesis, you're looking for a stenosis on the left side. Okay, so even if you, because when you scan the carotid artery, they scan both sides. You may incidentally found that the contralateral side is actually occluded significantly, but as long as it doesn't give you problem, usually we don't do anything for that. Okay, that end atherectomy applies for patients who has TIA. For patients who has stroke out, usually if it's in carotid artery disease or an internal carotid artery disease, there's not much that we usually do for the patient other than giving antiplatelet.
Okay. So this one no need done already.
Sorry, what's that slide for?
This one is the young stroke workup lah, but this is only for ischemia, so I'm not sure this one how.
It applies, just let me have a look. Yeah, pretty much cover a lot of things really.
Yeah.
May last, where's your CADASIL? Oh, CADASIL is there. Okay. Okay, fine.
Very, very long lah.
Very long, but and if you, okay, I don't expect you to mention things like Behçet or Church-Charles Wagner's. If you can just mention to me vasculitis, that's good enough. At least you keep that in mind that it's a possible cause of a young stroke. All right, can go on.
So risk factors. So these are the risk factors I found. So just one question about the hypertension. So the hypertension, dyslipidemia, diabetes, it doesn't really matter if it's ischemic stroke or the hemorrhagic stroke, is it? Or this is only for the ischemic one?
Dyslipidemia, diabetes, and hypertension are usually for ischemic. If you have hypertension, then it's higher risk for you to get hemorrhagic stroke if it's not controlled. Diabetes, dyslipidemia, we will screen anyhow if you have a hemorrhagic stroke, but they are not direct risk factors.
I see. So all of these, okay lah. I think it's nothing much here.
Yeah.
So this is okay. Maybe a little bit. Already 10 seconds. Oh, sorry, 10 minutes past the time already. So maybe a little bit on the young hypertension, doctor.
Yeah. Okay.
So doctor, what do you think is the cause for this hypertension this time, 180?
Oh, I don't know. I would like to look at things like the renal profile, to look at the potassium, see whether or not it's low. If it's low, persistently low, despite your corrections and everything, then maybe it's actually a cons or your primary hyperaldosteronism. Your aorta and your coarctations, you probably need a CTA to look for that. The rest of it, you still need to investigate, then only you will know what is the cause. Your Cushing, your pheochromocytoma, your stenosis, which things that you cannot see clinically until you investigate and we really look for it.
Okay. So Kai Xiang has a last, not last question. Okay. So he has a question. When
Mm.
should we refer to the interventional radiologist for the endarterectomy or embolectomy?
Endarterectomy actually is done by the vascular surgeon. The interventional radiologists do stenting. Endarterectomy usually, not say usually, you do it for patients who have TIA high risk, and when you do the carotid ultrasound, you find a significant, which is more than 70% stenosis on the symptomatic side. Okay, then you refer vascular for endarterectomy. Okay, embolectomy is out of picture here. We don't do embolectomy here. The next question is, do we usually give double antiplatelet for secondary preventions for stroke? Yes, there are cases which we give double antiplatelet. This is a trial which I mentioned, just chance trial that is done in China in 2015, where they look at what is the potential benefit of double antiplatelet in patients who have high risk TIA, meaning that if you got a TIA and your ABCD2 score is 4 and above, which is high risk, or those with mild ischemic stroke where the NIHSS score is less than 3, yes, they find a benefit of reducing risk of a further stroke if they give double antiplatelet. But we don't give double antiplatelet so long as compared to the ischemic heart disease patient. In this trial, they use a regime of 3 weeks antiplatelet, double antiplatelet, and then they revert to a single one. So yes, your Lizin, the answer to your question is yes.
So next question. So Adrian asks, when do we consider an AVM?
Okay, AVM is usually for patients who has bleed in areas which are not typical for hypertensive bleed, and of course when your patient comes in, do not have a high blood pressure. So those hotspots for hypertensive bleeds are usually your basal ganglia, thalamus, brainstem, particularly the pons. So if you have a bleed somewhere else further away in the frontal or the temporal pole there, they are actually very abnormal location for the hypertensive bleed, then you should think of other causes of intraparenchymal hemorrhage, not just AVM. It might be some abnormal vascular malformation there, or the patients might have a tumor sitting there and bled from the tumor. You can only know whether or not it's AVM, whether or not it's other forms of bleed by doing further imaging. Usually it's contrasted scan.
For Sumei Tan, she asked, I don't know, for what condition or how will the patient present hemiparesis ipsilateral to the lesion?
Ipsilateral to the lesion. Hemiparesis ipsilateral to the lesion.
Probably something the spinal cord before
You can if you have a hemi-cord syndrome, Brown sequence, but that is not really hemi. Usually your hemi-cord, usually it's not so high one lah. You need to hit the cervical to give you a hemiparesis. Anything below the medulla after the decussation, then it will give you a hemiparesis that is ipsilateral to lesion. But Brown sequence usually occurs in the thoracic cord, That's why you only got one limb that is affected.
Okay, I think that should be all. Any more questions? This is last slide already, I think. Yeah, last slide already. Okay, so any more questions? If not, I think we can call it a day. Okay,
Yep.
so I thank Dr. Fong on behalf of MEDSOC. So
Okay.
yeah, thank you for
Welcome.
your time and exceeding your 15 minutes a bit.
Okay.
I think
All right. Okay. Bye.
right. Okay, thank you, Doctor. Bye bye.
Okay. Bye bye.
Bye bye.
Thank you, doctor.
So guys, next Monday we have another session at 3 p.m. Okay. Okay. Done. I'm offing how to off.